Hi everyone, welcome to our 6th Serious Illness webinar today on patient identification. We're just waiting to get started, and if you'd like, you can take the introductory poll. I'll open it now while we wait to get started. So good afternoon, everyone, and welcome to our 4th, actually I think I said 6th before, but it's only our 4th Community Practice webinar. It's Francine Maloney, and I'll be your host for this event. So first of all, just thank you all for joining us today. It's a true pleasure to introduce Drs. Josh Lakin and Zhou. Josh is one of our palliative care faculty members at Ariadne Labs. You just presented a few weeks ago as well on workflows. And so in addition to all of that, Josh has worked on the implementation of the serious illness care program in both the primary care and the hospitalist setting, actually at Brigham and Women's Hospital down the road. And then Dr. Zhou is an assistant professor at Brigham and Women's Hospital in the Division of General Medicine, and her work really focuses on clinical informatics. So, before we jump in and get started, I do want to go over some webinar functionality as it can be a little bit confusing at times. We really want to make this as interactive as possible. So on the side, on the right-hand side of your screen, you should see a chat button and maybe a Q&A feature. Please feel free to chat or send questions in at any time. In addition, under that Participants tab, there should be a little raise the hand icon, and we will have discussion points. You feel free to raise your hand and we can unmute your line so you can participate in that discussion. And we do keep lines muted at all times just to cut down on background noise. So again, here's the team that's in the room today. So we have Josh presenting as well as Lee. And then your community team has, as many of you have interacted with us, is Dr. Rochelle Bernacki and myself, along with many others that sit here and abroad at this point. So as we like to always ground ourselves in where we are, this is our roadmap for the program. Today we'll be discussing patient identification, which is sort of in that plan implementation piece of it. I don't know that I don't think in this version of the roadmap we've called it out. We do want to share with you there's going to be a new version coming out that's much more simplified, and actually it's not called out in a step, but we hope to share it with you guys soon and get your feedback as well. So what you have shared with us is you are finding systematic ways of identifying patients, including EHR algorithms and clinician screens, such as the surprise question. You are tracking patients who have been identified and monitoring for conversations. And you are identifying, and you're saying that identifying patients remains a key challenge for many sites. Before we move on, just a reminder of what we did in the last webinar. We discussed adapting the guide, and we did that with Charlie Chen, who gave a great example of the hospice setting, and also Dr. Daniela Lamas, who went through adapting it for the chronically critically ill. We went through considering the role of context and having serious illness conversations. We reviewed lessons learned from surgical checklist adaptation. We described 3 adaptation processes, so the two I just mentioned actually, and then we integrated lessons learned from the current adaptation processes into efforts to adapt in your environment. Finally, today's objectives, we really want to understand the need for a system to identify patients who would benefit from a serious illness conversation, to be familiar with factors that may lead to a limited life expectancy, to learn to apply methods to screen patients and identify those at high risk of dying, and finally, to review barriers and lessons learned from commonly used patient identification strategies. I think we definitely have some lessons learned in there. So I'm going to hand it over now to Josh, who will work us through some of those objectives.
Fantastic. Thank you very much, Francine, and thank you, everyone, for joining this webinar today. We're going to talk, as Francine mentioned, about patient identification and selection. We'll go through a couple of different aspects of that work. It has been one of the more challenging parts of implementing this program for me here in the last 5 years. It's a very tough challenge, and I'm very glad that Lee is on the phone because she has been helping us to move that forward pretty dramatically in the last year and a half or so. So it'll be a good conversation. Looking forward to hearing your thoughts and your questions. But what we'll start with today is talking about what the need is. Why do we need a system for identifying patients for serious illness conversation? And the reason for that, it comes down to a couple of things. But for the main thing, or for the most part, we've learned that for patients who have serious illnesses, life-limiting illnesses, we know from a fair amount of data now that they don't have conversations about what's most important to them with their physicians, with their clinicians. If they do, those tend to occur very late in the last weeks to months of life and focus on medical details. And there's a number of reasons why those conversations don't happen or happen late. And a big one is because we don't recognize necessarily as systems and clinicians that patients need them. So we have a fair amount of data that while physicians we can kind of pick the directionality of how people are going, but we're not very good at defining how much time someone has left. The better we know someone, the worse we do, and we tend to systematically overestimate how long people have to live. Also, systems don't help us out too much in that electronic medical records and a lot of health systems do not have the tools that to help us out as clinicians for identifying patients earlier in the course of illness. What that leads to is both of those things together leads to us not knowing who needs conversations early enough in the course of illness. So there's some then key benefits to doing a systematic process for identifying patients. The first is that it helps to try and find people in that sweet spot for a conversation, right? So the work is focused on delving into people's goals and values in the context of an advancing serious illness. So not finding people too early, which is when they're healthy. There are tasks that are important for people to do when you are healthy, but the conversation, this program aims at conversations for patients with serious illness. And also not too late, which as I mentioned is our default pathway for our systems. The next, which is an important part and a challenging piece of this, is it helps us find a denominator for monitoring and evaluation of the program. right? So it allows us to know within a system, within a clinic, within a defined population of patients, who we need to follow for who needs conversations. It allows us to know who of those people have died, and also it helps us keep an eye on how the quality of our conversations are going. The next piece, which is something we've been learning over time and I think is not to be underestimated as part of this work, is that this is an emotional task for clinicians, choosing which of their patients might die. And so this work is important for getting their buy-in to the process and the practices around serious illness communication. So involving clinicians and choosing their own patients is really important for not only getting their buy-in to the kind of practical and systematic work of the serious illness care program, but also in building their accountability into having the conversations themselves. And then the last piece is that this encourages teamwork. Very few patient selection processes that any I've heard of are done entirely in silos. This is often a conversation between clinicians and the staff that are working around them on their daily workflows. So these are a very important way of continuing to kind of help coalesce patient care around serious illness conversations. So just to take a step back, I don't even know. I've probably said serious illness maybe 100 times already. So let me define that. The best definition is, as you think about this, I guess let me step back. If you think about who needs a conversation, the kind of easiest way to say it is that anyone with a serious illness needs a conversation. And a serious illness would be a condition or really a collection of conditions that carries a couple of different key factors. One, a high risk of mortality. So it's something that is carrying with your patient a risk of shortened lifespan for them. But it's more than that. It's also negatively impacting the way they're living their life and via their function or their quality of life, or burdening those who care for them and help care for them or the people around them. And this is from Amy Kelly, who's down in New York. She's done a lot of work around patient identification and defining this denominator issue for the larger area of palliative care. But I like this definition because it carries both the illness side of things, the serious illness, but it also brings into play the impact that it's having on people's lives. And both of these are important. And as we'll talk about, most selection algorithms focus on that top bullet because it's pretty hard to assess the other pieces. But clinicians, in the clinician side of the screen, clinicians, all of us, physicians, social workers, nurses, physical therapists, occupational therapists, and everyone else has a feeling in caring for patients what the impacts are on people's daily lives and their families' daily lives.
All right, so our first poll we really want to interact with you all is, and I'll get it started, what patient screening methods are currently being used at your clinic, hospital, system, whatever you identify with that, to identify high-risk patients. I'm going to open that poll now. Hopefully. Yep. And please select all that apply. And we're going to give you about a minute to do this. All right, so when looking at the results, it looks like some of you started the poll and might not have submitted. We will get to that in a second. But it does look like people use the surprise question, high utilization algorithms, whether that be claims or EHR data. Maybe some of you are using a clinical rule, and some of you haven't or don't systematically screen or identify high-risk patients. What we really like is if anyone would like to speak up about the state of their high-risk patient screening at their organizations, or in general, if anyone has questions so far, maybe if you wanted to answer the poll and it didn't work for some reason also. And feel free to, again, use that raise the hand icon to join in on the phone. If you also want to chat us a question, we're happy to read it out loud or to use that Q&A function.
All right, since you guys out-silenced me, I can talk a little bit about my first experience. I saw a few people had used the surprise question. So we started in primary care using the surprise question in the context of a high-risk care management program in primary care here in Boston. And what we did is we started by asking, as the clinicians, both nurses and doctors, were screening patients for this program, we asked them the surprise question, would you be surprised if this patient died in the next 1 year? Pretty quickly we got feedback that they didn't love that question. They asked us to change it to 2 years, so we changed it to 2 years. That question worked really well in a number of different ways. In listening to different clinicians tell stories about running their lists, I think we believe that it was pretty strong in terms of activating them for when they said, no, I would not be surprised if this patient died. They really thought hard about how they were going to have that conversation, what they were going to do with it. So it was strong in that way. It was very interesting to hear physicians in particular talk about how it really sparked their thinking around particular patients that they hadn't thought about much before. The downsides were when we ran the data, it wasn't particularly accurate, so it missed most of the patients who died in that group. So it missed a lot of people. So as we will be talking about, we're working hard on finding some algorithms that help to improve our predictive accuracy. So in primary care, where the pretest probability of mortality is much, much, much lower than other areas like cancer, the surprise question didn't work as well for us statistically as it has in other populations.
All right. If anyone else has a question or maybe their experience either with the surprise question or others. So someone has a question of what are the risks of misidentifying a patient?
It's a good question. So I think that, let me start with the easier one of those two for me, which is something I've been thinking a lot about with the surprise question, which is if we misidentify someone as a false negative. In other words, we miss them and they die anyway. The risks are that they don't have a conversation, right? So this isn't I don't know what a good correlate is as a screening test. Again, we're talking about a screening test. So the conversation is relatively low burden. It takes time, and it's something that is needed in our system, but it does take clinician time and busy clinician schedule. So, but for the most part, it's not harmful, and so there is no harm in doing these conversations. It's not like a screening CAT scan repeatedly for lung cancer. There's no radiation involved. So I tend to I worry more about these false negatives, which is we miss opportunities for conversations. A false positive is a different thing. So for a false positive in this conversation, it means you had a conversation with someone who didn't eventually die. My shtick on that in the place that I work, the people we're screening are sick enough, and a lot of places people are screening very sick patients. So these patients probably already have a serious illness, and it's probably one of the less predictable ones like COPD or dementia, heart failure, and this conversation will get things moving for when their disease invariably worsens. So for me, the risk of false negatives or missing people who are going to die is far greater than the risk of of screening in people who don't die in the period you thought they would, but are pretty likely to be seriously ill, especially with a surprise question.
All right, so we have built in more time for discussion, and we want to hear from all of you. We also want to make sure that we meet all of our objectives. So I'm going to move on and give it back to Josh.
Great. So let's talk now about the methods themselves. Right? So we've been focusing on the surprise question in that example. So let's talk a little bit about choosing and applying methods for identifying patients in need of conversations. So one point to make up front is that is important to think about. I think in my experience talking to people about this program, the first thing that comes to mind as the first step with this program is training. But identification of patients is really an important starting point for this intervention, right? So we start by knowing which patients or what population of patients we're going to be targeting with the intervention. And then, as you're thinking about doing that, it's more than just picking the way that you're going to do it. And I'm going to spend the next few slides going through the process. And this process is really important. I think in my experience, if you miss this process, you're likely to have a patient selection algorithm that is not met at the front lines where the rubber hits the road with activity, right? So the first thing is you need to gather a team, which must include your frontline end users, the people who are having conversations and helping you with the process. You need to review the possible screening methods for your population. Select the method. This doesn't have to be perfect. You can probably think about this for a long time and refine and refine and refine, but pick one, plan how you're going to do it, plan how you're going to track it and measure it, and then number 6 is implement and refine. So I'm going to go through each one of these individually. So the first is gathering a team, and this is incredibly important. I haven't met a patient selection algorithm that doesn't involve multiple professionals, right? So it's an interprofessional team, including clinicians as well as administrative and clinic staff, quality improvement people, IT and informatics people. Make sure you engage your leadership. So if keeping the program, but also the patient selection aligned with the strategy organization. I mentioned where we started in a high-risk care management program, so within an ACO. In the context of population health, a lot of our leadership was very much focused on thinking about ways to identify populations of patients with unmet needs. This slotted in very nicely, saying we can help identify a population of patients with very important unmet communication needs and serious illness. So linking it to strategy makes it easier to get resources to help do the challenging parts of patient selection. And then along with that is linking it to the organizational priorities. So 2, reviewing patient screening methods. I think I already talked through the surprise question in pretty big detail. And so just to reiterate, we use the 2-year surprise question. Again, this question is a little counterintuitive because the answer, no, I would not be surprised, is a positive screen. And people get confused about that, and I still do sometimes. And so people with the answer no are eligible for a conversation. I touched on the advantages. We think it has a pretty strong sense of clinician buy-in. There's good data to support it in certain populations. And it's getting more and more widely accepted. The disadvantages, I have concerns about it in populations that have lower mortality, where it misses a lot of people who die. And thanks to that excellent question, you kind of touched on why I worry about that. You missed opportunities in a low-risk procedure. So then the other approach is to use an algorithm, and Lee's going to talk about the one that she's been building here, which will be, I think, very helpful for people to hear. But there's the clinician screen, like the surprise question. On the flip side of that is the data screen. So using the computer to do things that the clinician would normally do, which is to assess elements of risk within a context of an illness or a combination of illnesses. People use different sets of data, such as utilization data or claims data. You can use EMR data for high-risk algorithms. You can also use clinician input data. There's plenty of sites and tools where a clinician will input particular pieces of data, which runs then an algorithm. And then we have a combination approach in here because I think it's almost universally unacceptable for clinicians not to be able to put a word in on this. So often then attach a clinician screen to a high-risk algorithm. So what we've done with Lee, and she'll tell you more about it, is we've run that algorithm. We passed it out to clinicians on a very small scale to start with, and for the most part, they identified exactly who the computer did, and they accepted and were pleased with the output of that algorithm. So the advantages of using the computer is it can narrow down to a smaller population, right? So when we did the initial surprise question, some of the clinicians were reviewing lists of 200 patients. That is not something I can ask them to do monthly. They would get pretty frustrated with me. So the computer screen narrows that down to a very small number, more manageable number of patients. Also, as I kind of mentioned before, a lot of healthcare systems now are engaging in predictive analytics for many different reasons, and can kind of leverage existing systems to do this kind of work. The disadvantages is this is not necessarily easy to do. It takes a fair amount of data cleaning. It took Lee, who is an expert at this, took us about a year to get the initial algorithm up and running and using data systems from different spots, and she's going to talk about how she pulled those together. The other challenge is a lot of systems are using utilization-based algorithms, which, thanks to Amy Kelly, we have pretty good data that says high utilizer does not equal high risk of mortality. High risk of mortality are often high utilizers, but not vice versa. So high utilization does not necessarily mean someone is seriously ill and needs a conversation. There's a lot of noise around particularly psychosocial diagnosis, psychiatric diagnosis. All right, Lee, I'll pass it to you for a discussion of the algorithm.
Hello, everyone. Can you hear me?
We can.
Yeah, great. I am and my team have been very fortunate to work with Josh and Rochelle to look into the possibilities of using clinical informatics methods and electronic health records to help identify patient cohorts for their serious illness care program. We are testing the hypothesis whether using electronic health records and machine learning will improve the accuracy of patient selection. Our initial goal is to double the accuracy of the current identification methods, which is mainly based on the clinician's judgment, like surprise questions. As we know that currently in our hospitals, we have a large amount of data stored in the electronic health records and our clinical data warehouse. For our project, we collected a 5-year retrospective data of patients with serious illness, including heart failure, COPD, chronic kidney disease, and dementia. We collected their demographic data as well as their clinical data, such as their comorbidities, medications, lab data, procedures, and their billing data, like utilization and hospital visit, etc. And we also get their death data from our EHR and the Massachusetts Death Registry. You see the figure here. We prepared the data set at each encounter level so that we can, based on the data before a specific encounter, we can use machine learning methods to predict whether the patient will die, for example, in a year or 6 months or 2 years. Next page, please. So this figure, this slide shows you how this works. We split the data that we collected into training and testing sets. We train the prediction models using the retrospective training data, and then we will evaluate the models using test sets to assess their performance, such as sensitivity and specificity. Our preliminary work based on structured data only can achieve like 45 to 50% of sensitivity for now. And we found that there's a lot of important information stated in the free text clinic notes and narrative reports. So we hope we will improve those methods, the models' performance by adding these new features extracted from free text using natural language processing techniques. So if this is successful, and we hope we can implement these predict models in real time to help our clinicians to identify patients that will be benefit for the conversation. Yeah, thank you. Josh, you can take over now.
Perfect. Thank you so much, Lee. So yeah, thank you for giving that overview of that. I think it's been an incredible experience for me watching you or Lee and her team pull together all these different data sources to try and use the computer to find different pieces of information. The part that's going to be very exciting for us is this next step of using the computer to search through notes, text of notes, to start picking up some of the later pieces of the definition of serious illness there. Can we see when there's drops in functional status, impact on caregivers, when people are having a decreased quality of life? So we're working on those pieces now, and it's been a fun and exciting piece of work. So moving on to the next step in this, which is putting your nickel down, basically. So selecting a method or a combination of methods, and then asking yourself a particular set of questions. So looking at your patient population and also the clinicians in space where you're working, you want to be asking, is this the right criteria for this patient population? And then, once you get that and you say, yeah, I think I've got something that will work for this population, then it's time to start looking at workflow. So what workflow and EMR, medical record system, paper or electronic, can efficiently support routine patient identification? Then going to the individual clinicians, trying to figure out, do clinicians buy into this method? What this method puts out, is that output satisfactory to them? Will they use it to have conversations? And then testing it out, which we'll get there too. Some tips which I've learned over and over and over is to keep it simple, especially up front. There's a lot of moving variables as part of this. It's not just picking an analytics piece, it's also the entire workflow and human factors, the clinician and administrative factors that go into it. So picking something complicated up front is doable but challenging. I would argue to keep it simple. We did the surprise question screening for a number of years before we've been doing this work with Lee, and so we are now fortunate that we're putting that algorithm into a functioning system otherwise. So we're changing the analytics piece, but I know the workflows that follow it, and they're changing a little bit, but not too much. I already know that I have clinicians buy in on this, and we just kind of are tweaking it and going for it. So keeping it simple up front is a good idea. Also, that something is better than nothing, which is, I think we can all spend a lot of time thinking and working through this, trying to get the perfect approach, which can take a long time. So take some time to, or just put your nickel down and choose something, because it's better than nothing. And then the last, which we'll get into, which is test the criteria a little bit before widely putting it out there into workflows to make sure that it's coming up with something that is working for you. You want to make sure that you can pull it off, your lists are not too big, clinicians don't revolt, those kinds of things. So making sure that you have something that you're testing in a small group. Like when I first ran that algorithm with Lee, I sent it out to 5 doctors to get their input, right? Even though we have many, many implementing clinicians. So then planning the workflow. So the workflow piece of this is, I guess I won't compare the two. It's just as important, if not more important, than the actual algorithm itself, because your goal is to get this tool, this identification algorithm, the funnel that is helping you go from a large population down to a group of people with whom you want to have conversations, into what are, as we went over in the workflow piece of things, complicated, very complex, human-run, busy, overstressed workflows in the clinical world. So the goal is to get it in there with a minimal disruption to what clinicians on the front line are doing. So once you've picked which screening tool you'll use, start thinking about questions like who on the staff will oversee the process of patient screening. For us, it was nurse care coordinators who really picked up and owned this piece, and they did it in different ways, so I didn't define their workflow to it. So the next one, in terms of picking what is a routine time and place to screen patients and at what frequency will it occur, we left that up to them, but we did talk it through, so they had to tell us kind of how they were thinking about doing it. And they each did it differently based on their different workflows. Some of them would print lists and take them around. Some of them would grab the doctors and sit down and do it together. Some of them would do it, each of them do it independently on the electronic survey tool we had. So people did it in different ways, but we defined who, when, and at what frequency. Then the next piece is the data side of things. So where will the screening results be recorded? You want to make sure you keep the date and how high of a risk people are. So are they in need of a conversation now? Is this someone who may need one in the future but is not top priority? And then keeping track of that system and also making sure that that interacts with your system for tracking conversations, right? So you're picking this group of patients. You want to be able to also track who's had a conversation. And along with that, data doesn't often enter itself, so who's going to be responsible for entering the patients into the database and keeping track of that data, keeping it up to date. And then the last piece is think about how you're going to get input for frontline users on the screening methods and the workflow. Last, but second to last and not least, we already talked about this quite a bit, but it's important to plan the tracking and measurement piece of things up front, which is the whole point of this process is to build a list of patients who need a conversation so that you can know if they had a conversation. And so that way you'll be able, by building your tracking up front so that you know this population can track them is very important. So build that into your plan going forward. And then last but not least is the concept of the PDSA cycle. And I've already touched on this a couple of times. It's a fantastic concept from the Institute of Healthcare Improvement here in Cambridge. And the general gist is that you should try something on a small scale, learn from it many times before you launch it to a big scale. So the Plan, Do, Study, Act cycle is very applicable for patient selection type activities. So taking time to plan what you're going to do for patient selection, choose your algorithm, plan your workflows, and then test it in a very small group of clinicians. Like I mentioned, we did it with 5 the last time we did it, even though we've been doing this for a long time. Didn't want to roll it out broadly. We did it. We then learned from it, making some changes, and then we'll do it again. So the PDSA cycle has everything to do with planning in advance, testing it, do a small test of change, making whatever changes you need, and then doing it again with that. So this is a very good way to do patient selection before you do a big rollout of lists that don't work. I've heard of a number of stories of that happening. I've been guilty of doing that in many, many different ways. Fortunately, with patient selection, we've started small.
All right, so we have the second poll for you now. I'll open it up. So there's 3 parts. I want to make sure you scroll all the way down. The first question is, have you tried to implement a systematic patient screening identification method? The second question is, if yes, have you implemented a systematic way of tracking conversations for patients who are identified? And then the third question is, what barriers currently prevent you from systematically screening patients? And for that one, please select all that apply. And when you're in progress, just make sure to click the Submit button. We see a few of you are in progress now, so that we know to get your results. And we've given you a little bit extra time on this one since there are 3 questions. All right, so thank you so much first for answering the poll. A lot of you are currently in this process or haven't yet tried, and then of those who answered yes, again, it's just the same. And then the barriers, they're sort of even across the board, which is what I would say we expected. So you're not sure how to get started. Resources, similar, okay. And then similar, or not similar, but also I want to implement an automated system, but not sure how. So we're going to open it up again for discussion, and as we wait for your hands and questions, I really just want to reiterate what I've been learning and hearing from Josh and his statements, and just that the most important thing I think I'm hearing from you is start small and get those people on board in the clinics and find a strategy, and then this is the overall goal. Get this team, this larger team together, and if you do need to automate, we also recognize some of you might not need to automate. Maybe all of your patients are eligible because you're in hospice, and so it's more about how to prioritize those patients and how to have conversations. But we sort of recognize that this might be a big task, and this you don't have to get this perfect in order to start the program. Actually, you shouldn't have this perfect in order to start the program. So go ahead, Joe.
No, I was just going to say a number of people there have mentioned that they don't know how to get started, which I think is a very important and difficult challenge. And Francine and I were talking about this earlier. I think especially actually everywhere, but especially in places that are implementing small, I would argue that probably one of the best ways to get started is to just pick a couple clinicians who you know are champions and ask them to sit down with you and kind of tell you how they would prioritize and choose which patients are in need of a conversation. And if you can give them some guidance in terms of things that might be helpful. So let's talk about your patients with heart failure. Who of them do you think need conversations? And then take that information and try and operationalize it in some sense, make it happen upstream just a little bit, and think about a process for doing that. So make a process that meets their needs first. That'd be especially if you don't know where to start.
So we got one question in, and this is a great one. What's the actual intervention that's performed after patients are identified?
Sure.
So do you want to?
Yeah, you mean, so I guess it kind of depends on where in the process of the serious illness conversation program you are. But I think if you're talking upstream from the funnel standpoint, so say you're running an algorithm like the surprise question, the patient comes out of that list, and so now you have Mr. Jones. All right, you have Mr. Jones. He's been identified by a clinician as surprise question, no. The process for what happens to Mr. Jones is a workflow problem, right? And that's kind of what we've been talking about from workflow. So you now have Mr. Jones, and you have whatever Dr. Smith or Nurse Smith or NP Smith who identified Mr. Jones for a conversation. The question is, how do you deliver that name to that clinician to trigger them to have a conversation, right? So the workflow that goes from taking a list of patients, so for our ICMP program at a given time we have probably between 150 and 200 patients who are identified for conversations, and we distribute those lists to clinicians in their workflow, so via email to nurse care coordinators who meet these clinicians in their workflow to have the conversation. Once a patient is identified and triggered, then the process is a guided conversation, so getting a clinician in the room to sit down with someone, talk to them about, or introduce the conversation, talk to them about their understanding of where they are with their illness and how they would like their information, have a prognostic discussion about how their disease is going, tailored to what the information preferences and needs are, and then ask them the series of questions about their goals, their values, fears, worries, strengths, trade-offs, functional status. And then using that information to drive care going forward, which maybe is, for many people, if it's early, it's just revisiting that conversation at a future time. For some patients, if they're late in their illness or if they have very particular goals and values, could be a change in the way they're getting care from the healthcare system.
We do have one question for Lee as well, so I'm going to unmute your line, Lee. But do the machine learning models find any predictive features that are surprising to you or surprising to the clinician?
So, thank you for this question. This is a very interesting question. This is a great question. So we haven't, our algorithm models are based on the features that we think is important based on our knowledge, like our clinicians' domain knowledge. Like we selected the critical labs and look at the trend. We look at the competitors, their encounters, how many hospital visits in the last couple of months, et cetera, et cetera. So those are the features that we currently incorporate into our model. Basically, is we have a lot of hundreds of thousands of features put into the algorithm. The models will select the features that can help predict the mortality automatically, and we do pre-select some important features that we think is important. So those features is not necessarily very surprising to us for now, but we do also looking at the nodes. We look at the nodes. We use some unsupervised machine learning methods that topic modeling, and we let the machine read all these nodes and identify what has been documented in the nodes. We found out, actually, not surprising but interesting things like what kind of care, what kind of palliative care, interventions, when our physicians document there. That means maybe when they start to talk about it with their patients. We found, Josh, you can comment more on that. We found not until the last 3 months that the intervention, the conversation started, talking about palliative care related topics with the clinician. I don't think this is a surprising feature, but that means that there's a lot of work for our clinicians to do, maybe, to start the conversation earlier, to start some important interventions earlier. This is just some experience we have learned from the experiments.
Exactly. Yeah, and Leah, it has been very interesting to see the information coming in the notes, because and just to kind of highlight what Leah just said, the initial part of this algorithm, we fed the computer the large list of variables and information we thought it should analyze. As we go into the notes, the computer is going out and pulling that information and displaying it to us. So I think that as we go forward, we'll be getting Leah's been pulling together these groups of words that the computer is finding that are correlated with increased risk of death. So the short answer is, so far, nothing surprising, and it's consistent, I think, with other data. There's not one smoking gun out there. It's not like it's creatinine plus blank. It's a huge number of data variables that have small, complicated, multidimensional ways in which I can't understand that they affect the prediction of this. So it's a great question.
I think that's not surprising. Maybe it's not a bad thing, because this means that the important factors that our clinicians know about it actually is important.
Yeah, exactly.
Yeah.
Okay, just to finish up here, make sure we provide you some lessons learned. We'll move it on to Josh.
Oh, sure. So closing up today's discussion, one of the first points that I made earlier was make sure you have thought about, if not fully kind of baked your first PDSA cycles around your patient selection before you train clinicians. And then when you train your clinicians, you'll be able to tell them about the patient selection piece, which gives them the first step in the program that they should do after they leave training. So launching trainings only once you've had your patient selection piece done. So that's one key takeaway from today. Next, which I think all of us have kind of hammered away at. Yeah, I can't use, metaphors around horses don't work here. So make sure you start easy and small and engage your frontline clinicians. So it's happened a few times. You pick small, you pick pick your screening algorithm. If it doesn't work, if the clinician doesn't identify anyone, then we did this a couple times. You sit down with a clinician and say, okay, fine, You can even look at the same list. Generally, the same list yields people, and you sit down and talk with them about it. So then from a conversation standpoint, and Francine got at this a little bit, which is a prioritization. So you build a list. Something that we've learned that we haven't talked about today so much is I encourage clinicians now when they do their patient screening to start with the easier patients first. We learned that the natural tendency, which I think is pretty common, is to think of the thorniest, toughest, most stress-inducing patients that we have and want to tackle them first, and then do all of them first. And that kind of results in clinicians getting frustrated and tired and kind of burnout around conversations, picking the hardest, most challenging patients first. So I suggest once you look at your list, look at people who are the easiest ones on there, the ones who you kind of know, they already know, and in fact, maybe even might be on hospice already. Just start with them to have the conversation. And then last, some points from earlier on. These conversations are ideally started 1 to 2 years before death, so the screening method should be focused on identifying patients in that period, the earlier time period. But focus your methods on your local context. Take a look at the medical records and data systems you have at hand, and your stakeholders, frontline clinicians, leadership. And then we talked a little bit about options such as the surprise question as a clinician screen, algorithms, or combining both.
All right, we have one last poll for you. Actually, there is a wrap-up poll. I don't want to lie to you. So the next one is if you've developed a low-tech approach. So we've talked a lot about high-tech, except for the surprise question, I would say could potentially be a low-tech approach. To identifying patients, would you be willing to discuss it with someone from Ariadne Labs? So I'm going to open that poll now and get you started. We have about 5 more seconds. If you're in progress, if you can just hit submit, that would be greatly appreciated. All right, so we see someone someone was raising their hand. If you still have a question, we would be happy for you to open up your line. But we did get another question in as well, which was, let me see if I can, yep. Can the speakers elaborate on the chronic conditions that they have identified as being most predictive of patients who would benefit from, I'm assuming, like these conversations?
Mm-hmm. Sure, it's a fantastic question. And I guess the very short answer is all conditions can benefit from a serious illness conversation. But to take it further and make it a useful answer, it depends on the different conditions, right? So the way I think about it is, I mean, and again, you can start with the most common chronic conditions, things like CHF, right, heart failure, dementia, COPD. Each of these things has their huge disease burdens in our population. They have criteria and characteristics which have been pretty well defined. For example, heart failure, I was talking to a cardiothoracic surgeon recently who is kind of teasing me about the complex patient selection algorithms and said basically anyone who has heart failure who's been hospitalized has a very high risk of dying in the next several years. You can't convince me they shouldn't have a conversation like this, right? So each of them has characteristics that range from pretty straightforward to more complex that do flag someone with one of those illnesses for a serious illness conversation. So I would argue that if you have a broad population and you're wanting to try and focus to one or two chronic conditions, picking one that is very common like heart failure or like COPD, where they are very important conversations considering the unpredictability of the future and the high burden of symptoms of fatigue and weakness and shortness of breath and difficulty with decision-making around medical interventions and a high interaction with the healthcare system. Those are great conditions to jump on early, and there are criteria out there. Dementia is another good one. It's a little more complicated because of the kind of loss of decisional capacity that goes along with that illness, but it's another one that is important where decisions get very challenging and stressful towards the end of life.
There's a really interesting article in the New York Times this weekend about dementia-specific directives that Barack wrote, and there's some interesting discussion about it as well. But that, in general, that conversation still has to happen with someone who either has mild dementia or is at risk for dementia. And usually by the time someone has moderate to severe, they're not able to have that discussion. So.
Yeah. Other conditions like cancer, each one of them, people will simplify it to anyone with a metastatic solid tumor, right? Yeah. And that maybe gets a little more complex in breast cancer and prostate cancer, but even still, this conversation can be helpful for people who have metastatic breast cancer, even if we hope to keep their disease at bay for a long time.
Great. If there's any other questions or comments or ideas that you guys have started, not even ideas, projects, that you guys have started, feel free to continue to chat or send those questions.
And thank you for being willing to share your experiences with us.
Yeah,
I appreciate that.
So this now is the last poll, I promise. On a scale of 1 to 10, did this webinar meet your needs? So 1 is not at all, and a 5. I think I said 10. On a scale of 1 to 5, I'm sorry. And a 5 is very much. And then if the webinar did not meet your needs, what did we miss? So that poll is open now. And I'm just going to continue on with the slides, but you can continue taking that poll question. Actually, to point out, the second is a short answer question, so you can type in your answer. It should say your answer, and you can type it in there if you have feedback for that one. We want to let you know that our next webinar is on Tuesday, February 13th. It's going to be at noon again, and our presenters are Dr. Pippa Schulman and then Hannah Luken-Stallman. Hopefully I'm saying your name right, Hannah. And it's on integrating the conversation, but also all the components with your EHR. And most importantly, we just want to thank you all for joining the webinar today, and thank Josh and Lee for presenting on this really complex topic.
Thank you, everybody.
So, yeah, and we look forward to having you all participate on the February 13th. Thank you.